Who's the iPhone guest in our room? Can you identify yourself?
Hey, Cam, it's Roger.
Thanks, Roger. I'll update your name.
Thanks.
Hi, everybody.
Good morning, Madam Chair. Madam Chair, I hope we get 3 more participants joining, but I just had Emily cancel, so potentially cancel. So I'm hoping we have a quorum. There's Kevin, so now need 2 more, Madam Chair.
Are we streaming it?
I can hear you. You're kind of soft, though.
I think Lori asked if we were streaming it, Cam.
Yes, I did. Thanks,
Yeah,
Roger.
yes, we are. We're streaming.
How many members?
We don't have quorum yet.
I know, but on the agenda for the roll call, it lists 12, but there's only 10. Number 10 was missing.
Oh,
So
gotcha. Okay, then we just need 1 more. Sorry. And we have 1 more.
All right. Welcome everybody to the Arizona State Board of Pharmacy Task Force Stakeholder Meeting on Rule Writing. Today is January 29th. The time is 10:01 a.m. and I will call the meeting to order. Dr. Gandhi, can you do roll call and conflicts of interest, please?
Certainly, Madam Chair, thank you. And good morning, everybody. Ms. Walmsley,
Present and no conflicts.
Mr. Borg,
Here, no conflicts.
Ms. Nair. Not present. Mr. Dang,
Present, no conflict.
Mr. Pond,
Present, no conflict.
Ms. Howe, Mr. Schwartz. I did see Jamie. Jamie, are you standing in for Mr. Schwartz?
Oops. Sorry. Yes, I will be standing in for Mr. Swartz.
Are you okay with that, Madam Chair?
Yes, I have no objections.
All right, I'll document that for our records. Mr. Bozen, Mr. Morris,
Present, no conflicts.
Ms. Almer, and Ms. Patel. Oh, you're muted, Dina. I do see you, so I'll note you as present, but if you can work on your mute
Can you hear
button,
me
that'd
now?
be great.
Can you hear me now?
Yep, I got you now. Mr. Bozen, Mark, can you hear me? Mark, I see you.
Mark is here.
Yep, I think I can hear you.
Great.
All right, so Madam Chair, we do have a quorum. Just good news. We have a couple of people missing.
Awesome. Well, if anybody joins later, we will add to the group. I think we have one agenda on the item, which is something we've been working on for a little while. It is updates to R 423, 410, which is the compounding regulations pursuant to the new USP updates. So, Dr. Grande, I don't know if you want to display it on the screen or where you'd like to start, but I know a draft was circulated with the task force members, so I'll take your direction on where we want to go next.
Yep, I am working on sharing my screen so we are all on the same page. All right, everybody able to see my screen?
Yes.
Yes.
Okay, so Madam Chair, if I can take over a little bit here and
Yes, please.
we'll go page by page, section by section, so we have all the bases covered. But this is primarily a draft that Mr. Bozen had drafted. There are some comments in here after review that we can discuss in more detail. This obviously has been an agenda item for some time now. And the reason that's the reason we only have one, because we do need to address this and hopefully put it to rest with language we can all live with, I guess. So if I can get started, I think, Mark, your first comment was there's no definition of compounding in the administrative code, but it is in statute. Do you feel, or does the task force feel that, I mean, obviously statute trumps the administrative code. Do we need another definition?
No, I didn't propose one. I was just noting that the definition is found in the code. That was my intention for just throwing that on this page so that folks knew what the current definition was. And if there's any need to change that, that would have to go to the legislature. So I threw that up at the beginning of the document just for information more than anything else.
All right.
And there is a bill that has some other changes to it that's pending with the legislature. So if there was a need to change this definition, now would be the time to talk about it. I don't think there is a need if anybody wants to know my opinion.
The only thing that I was thinking about when I was reviewing the draft is, do we need to say what compounding is not? So we say very clearly that compounding is not, the flavoring is not compounding. And then I think the prior discussions, not necessarily with this committee, Mark, but when AZPA and yourself appeared before the board, there was some talk about whether or not there should be some carve outs from what was considered compounding from like the broader enforcement just like pieces, since the definition of simple compounding was removed from the USP chapters. Like I think the discussion was around things like making like miracle mouthwash and those kinds of things, but I didn't see that memorialized into this, and I don't know that I have a really strong opinion, but just thinking, do we need to think about what compounding isn't in the definition?
I think we
It's a good-
further, I think the compounding definition gives you a common framework of what to work with. And then it's further carved out into what is and what isn't in the rule, right, Mark, if I'm correct? But it does give you a framework to go off of, is my understanding.
I would agree that the definition is more difficult to change because this committee doesn't have the ability to do that, only the legislature. The definition does include some nots. The last sentence is, compounding does not include preparing commercially available products from bulk compounds or preparing drugs for sale to pharmacies, practitioners, or entities for the purposes of dispensing or distribution. So that was aimed probably historically to the manufacturers and other people that supply things to the pharmacies. Just to be clear, those are different kinds of entities that prepare finished dosage forms for pharmacies and practitioners to sell. But to Cam's point, what we do have control over is the list of things that we'd like to pull out from the definition in our 423, 410. And there are 5 proposals here. We can add some more. And so yes, that's on the agenda, is to talk about what it's not. There was some consensus from the board that simple flavoring shouldn't be considered compounding. Tablet splitting shouldn't be considered compounding. Things like that. Reconstitution has never been considered compounding, so long as you're reconstituting consistent with the FDA-approved labeling that directs the pharmacist or the technician to reconstitute in a certain manner. But it's restated here to make it more clear. There are some comments where, for example, number 1, C1, I know I'm going out of order a little bit, but that says, administration, preparation of a single dose for a single patient administered within 4 hours. Yes, that's part of USP. That's not different. But if you're listing things that aren't considered compounding, the target audience in my mind are pharmacies that don't compound and may not even have access to the current USP 795 or 797 chapters, because those are things that cost money and wouldn't be required in a non-compounding pharmacy to have those. And so these were some of the common things that you could carve out so that the universe of permittees and licensees could know very clearly these are things that you might commonly see in your practice that wouldn't be considered compounding. I did not include in that list, Madam Chair, is the very, very simple compounds, like a magic mouthwash that is 1 part viscous lidocaine, 1 part Maalox, 1 part Benadryl, or whatever magic mouthwash recipe the provider prefers. And that's absolutely something we can consider adding.
Uh, Prior to getting into that discussion, as to number one, I understand it's addressed in USP for immediate use. Is there some sort of stuff in the USP standards that even though it's for immediate use, you still have to follow some sort of sterile techniques and stuff like that? Or will this generic language omit from any type of sterile technique to be utilized?
Well, I'm assuming you're talking about sterile technique in the vernacular that's used generally in hospitals, which is safe. It's a safe practice. It's different than what pharmacists are going to refer to as sterile technique. So, for example, in our world, sterile technique involves donning garb and having an ISO-controlled environment and primary engineering controls and secondary engineering controls. But when you talk about sterile technique, when it comes to self-administration or in office or in hospital bedside administration, you're talking about much more simple things like making sure that the rubber stopper is clean with an isopropyl alcohol swab and cleaning the site of the injection quickly. And so administration, preparation of a medication prior to immediate use is not done in a sterile environment generally, but there are best practice safety techniques that we often refer to as sterile practices or sterile technique, but that may confuse the reader, and we should probably be more clear about what the difference is between compounding in a sterile environment and compounding using professionally recognized standards of care for self-administration or bedside administration.
And I think USP for immediate use already kind of addresses that. So should we just address it through reference? I mean, you don't have
could
to
do
have a
that.
sterile room and stuff, and because I think it's going to get kind of tricky to identify each, like, oh yeah, you got to wipe the rubber stopper down, you got to do this, you got to do that, right? The technique is still the technique, but I think it's already identified in USP.
That's absolutely fine. Like I said, it may be superfluous and unnecessary because even though the USP chapters cost money, they're available and people can go find them. We could reference that, and we do reference it here at the beginning. And B, capital B.
I mean, if we want to clarify further, we can just say using aseptic technique, preparation of a single dose for a single patient using aseptic technique. Just add that there so that, I mean, it's nursing practice, right? It's basic nursing practice. But if you want to further clarify that, we could add that statement.
Yeah, but then we got to define aseptic technique, you know, so it gets confusing. If we just, again, it's already there. I'm not sure if it warrants reinventing the wheel because I think USP already identifies and addresses that issue. So is this fair just to make that note, reference USP to avoid confusion, and then we'll just piggyback off of the language in B and carry it over? Is that fair?
I don't have an objection.
Okay.
Any objections from the group? I don't.
Madam Chair, this is Kevin. So going back to Mark Bosan's comment about compounding Miracle mouthwash. So I know it's 1:1:1, 30 ml of Benadryl, 30 ml of lidocaine, 30 ml of Maalox. Sometimes those do come in unit dose. If it's all unit dose, all we have to do is just pour them all into the bulk bottle and mix them together. But there are times when we cannot get them in unit dose form. So that means we have to utilize the cylinder to measure the quantity and use the other equipment to make sure that all the volumes are correct. So Mark, in that case, would you consider that as compounding if the technician has to use the cylinder, spatula, and other compounding equipment?
Madam Chair, I don't know if you want to address that now, or you wanted to talk about that later. I'm happy to
I
answer
think
the question.
let's keep going till we get to that part of it, Mark.
Okay.
Okay.
Okay, so I know we just jumped ahead, but any other concerns with A, or there's no change in A?
No
Any
change.
concerns with B? C, and then C1 we just kind of addressed. How about C2? C3? So when you so I do have a question on C3. Repackaging of commercially manufactured drug product is not required to meet the standards in this document. What if it is like a hazardous product or something of that nature and they're repackaging?
So I may ask Roger Morris to help me with this. This is something he and I and many of you have struggled with for a long time. My intent here, and as I read it now, many weeks after I wrote it, doesn't go to the intent. I was going to the concept of eaches, and Roger, you know what I'm talking about here.
Yeah.
Okay. And repackaging might not be the right word, because repackaging is a word that's defined in federal law and generally requires a manufacturer permit.
Correct.
But it's the breaking up of, to Kevin's point, a thing that might come in unit of use, but it's a flat of 25, and I only need one. And I'm not manipulating anything that other than the outer manufacturer packaging. And maybe there's a more elegant way to word this, but what I wanted to do was create a concept where a pharmacy could break apart a manufacturer container, only molesting the outer container but not the inner containers, and being able to not call that compounding and be able to distribute one of something. And the public policy benefit of that is avoidance of waste, avoidance of shortages, and other things. And the quintessential examples of these are helping a dentist's office stock a crash cart that hopefully will never ever be used, but they need 1 amp of epi and 1 vial of Benadryl, and they just need one, and they just want to buy one, and they don't need to buy 25 and throw 24 of them away, and they're going to buy them every 5 years or however often they expire. And I thought this might be a place to put something like that.
So, Mark, let's talk about that a second, because we're talking about compounding here, but typically the eaches concept is a wholesaling problem, not a compounding problem, because pharmacies sell to doctors' offices all the time 20 pills, or I think a pharmacy can send over 1 vial. To be able to do it. I'm not sure this fits in the compounding section. I agree with the concept. I'm just not sure we need it here in compounding.
And that's a fair point.
So is there objection just removing this line right now for in the interest of moving forward?
If I can speak up from the hospital standpoint, so oftentimes we'll get like a bottle of a liquid, right, 473 mLs, and then because we have to distribute in unit doses to the nurses, we will repackage from that bottle, and we'll make like 5 ml, 50 doses for the patient, for individual patients. But it wouldn't be patient specific, but we relabel it with the lot number expiration. So we're kind of technically repackaging, and these are non-sterile oral compounds, oral liquids, and non-hazardous. So I don't know.
I think Bina, if I can jump in a little bit, that may be considered pre-packaging, and I think pharmacies do that today, right? Because the inventory is still yours as a hospital pharmacy, and it's staying within the confines of the hospital. It's not leaving. I think the intent here is that your hospital pharmacy would repackage and then distribute it out to other hospital entities, right? That's what the intent with this repackaging is, not pre-packaging.
Got you. Okay.
Cam, can we go back for a second? I apologize. On C2, I just want to make sure we're clear, because the world keeps changing. On reconstitution, it talks about a commercially manufactured non-sterile product. I presume what we're talking about is a manufactured product.
Correct.
But because 503A pharmacies can now purchase product from 503B, and in some states 503Bs are listed as manufacturers, I'm not clear where those fit into this and other concepts here.
Does the word commercially cover that concept, Roger? Because that's not, no, a 503B is not necessarily a commercially available product.
I'm just not sure. I take it we do not want a pharmacy to be purchasing from a 503A, reconstituting from a 503B.
Yeah.
I'm trying to figure out.
Thoughts from the committee?
Well, it's interesting. I'm not sure that commercially is necessary. A manufacturer is a manufacturer.
Well, but a bunch of 503Bs are licensed as manufacturers in their states.
Correct. But let's play it out. I haven't come across a 503B that medication that needs to be reconstituted before administration. But if it did, why wouldn't we allow it?
That's what I'm asking.
Okay.
Dr. Gandhi, is Kevin again. Going back to C2, if it's possible, should we consider adding the word unit dose somewhere in that sentence? For example, reconstitution of a commercially manufactured non-sterile unit dose product in accordance with the direction contained in the manufacturer approved labeling. It's not required to meet the standard in this document. The reason I mentioned that is because more and more manufacturers are now selling us like a kit. For example, lead gel kit. When it comes to us in a kit form, every single drugs come in unit dose. All we have to do is just follow the instruction, add this to this, add that to that, and mix them together. That should never be considered as compounding. However, if sometimes the kits are not available for us to purchase, they're out on back order or not even available. In those circumstances, we have to rely on the multi-dose vials. We have to take out a multi-dose lidocaine vial, a multi-dose tetracaine vial, a multi-dose raised epinephrine vial. We have to follow the formula that's provided to us, and we mix everything ourselves. We measure them. We use a cylinder, all the equipment that would need that we would need to compound the lead gel. So in that regards, I think number 2, if you mentioned, as long as it comes in unit dose, that there's no measurement needed, then that should never be classified as compounding.
But Kevin, take a bottle of amoxicillin that you reconstitute. That's not unit dose.
But then that's for patient-specific use.
But this
Right.
applies more broadly. I wouldn't consider reconstitution of amoxicillin
Yeah.
as compounding.
Yeah, me neither. But you do it for one patient. You follow the instruction though. On the back of the bottle it said add
I think
75
I think Mark's already defined definition was fine for what you're talking about and what like Mark is talking what Roger's talking about with like an amoxicillin, for example.
Yeah. See, number 2, if you don't put unit dose there, commercially manufactured, well, multi-dose lidocaine, multi-dose raised epinephrine, multi-dose tetracycline, those comes from are commercially available. So it's confusing all of us, the technician and pharmacists too.
So
Kevin, what my intention here was, if you've received a product and it says before dispensing to the patient, do this, and that's part of the FDA approved label. It could be adding water to amoxicillin. It could be adding the vial of ethyl alcohol to the clindamycin topical. There's lots of reconstitution we do all the time. It's not just water. It's not just ethyl alcohol. But when we're following the FDA's approved labeling that comes from the manufacturer, that's never compounding. And that was my intention. And it could be unit of use. It could be a whole 14-day supply of amoxicillin. It could be a whole 30-day supply of clindamycin topical. But my question to you is, in the case of, I've got clindamycin, but I don't have the ethyl alcohol. I dropped it, I lost it. I'm going to take ethyl alcohol and put it in a graduated cylinder and make it the same way.
Yeah.
Do you want that to be considered compounding
No,
or not?
no, not because it's for for a specific patient use. You mix the clindamycin, it's only supposed to be dispensed to Kevin Dang. But then why would that be considered as a compounding, right? But what I'm trying to...
Well, I'll, as much as I want to deregulate this, and I really, really do, I would actually say if I lost the little vial of ethyl alcohol from the clindamycin manufactured container, and I supplement that with a small amount of ethyl alcohol I get from the shelf from the OTC section, that should be compounding, and here's why. Because if there was ever a recall on the ethyl alcohol from the manufacturer that wasn't the clindamycin manufacturer, I'd want to make sure I have a compounding record and know that I got to recall that clindamycin that I used, the stuff that didn't come with the box. And on the amoxicillin one, and I've done this before, worked at a small pharmacy. I had one dose of amoxicillin. It's only 200 milligrams per teaspoonful, but the doctor wanted. Actually, I had 400 milligrams per teaspoonful, but the doctor wanted 250, and I ran out of 250s because everybody's got strep throat. So I over dilute the 400 using my using the math skills I learned in pharmacy school and grade school. That's compounded because I'm straying from the manufacturer's directions, and I don't want anyone to have any mistake that even though I used an NDC that looked like it was 400 milligrams per milliliter, I diluted it appropriately to 250 milligrams per milliliter, and I ought to document that in a compounding log and make sure that I've got good evidence that I diluted it correctly. And so when we stray from the my goal here for number 2, and I'll stop talking, is just to say, hey, if we're following the FDA approved manufacturer instructions, it ain't compounding.
I added some language, and I don't know if it clears it up. Reconstitution of a commercially manufactured non-sterile FDA-approved product is in accordance with the directions contained in the manufacturer FDA-approved labeling, is not required to meet the standards of this document.
I think that's fine.
And I don't know if the following language is needed or not for the purpose of filling a patient-specific prescription.
I don't know that it's necessary.
I don't know that it's necessary either, because I don't know of an instance when you would do that it wouldn't be for the purposes of a patient-specific prescription.
All right.
And then the one thing, and I don't know why I use this language, I think I borrowed it from someone else, like another state, but I keep saying in this document, and I think it should be in this section.
Yeah, I agree.
I'm sorry for that.
All right. So I think the addition of, I'm sorry.
On the top, if you can go back, Cam, would that also mean in C1 you would put in this section also?
Yes. Actually, we will probably just
We'll strike 1.
You want to strike it altogether?
Well, didn't we decide we were just going to reference the USP? Or is that what you added?
Begin the preparation in compliance with USP. So I was just going to strike this part, take what's in B and then substitute it in. So the in this document wouldn't even come into play in the new language.
Okay. All right.
And I think we addressed C3 already to remove it at this time.
Yeah.
C4, splitting tablets, breaking or cutting. And again, it's a similar concern as I had prior. What if it is a hazardous waste product?
Well, could we hold that thought? We're going to get down into some modifications that we might consider for 800 later in this document.
Okay.
And then if we go back, so my proposal would be, and I'll cut to the punchline. I would like this committee to consider whether or not we use the entire NIOSH list, like USP does to define hazardous drugs, or only use the two most dangerous categories, which are category 1 and 2. Those are predominantly the anti-neoplastics and others. Category 3 is all products that just present some teratogen risk. So those are your hormones, your fluconazoles, and other things that are dangerous when consumed by women of childbearing age or women who are pregnant. But if we're using appropriate respirators and negative pressure rooms or appropriate respirators, we're not going to use negative pressure rooms for 3s. But if you're using appropriate biosafety cabinets, respirators, things we're using today, then do we really need to treat all the category 3s the same way we treat the anti-neoplastics? And so, for example, we could, if we decide to do something different with USP 800 later on in this conversation, we could go back to number 4 and say, except for the drugs that are deemed to be hazardous in this section. But even USP 800 has some exceptions for tablet splitting. But we can get back to that later. So I think we need to talk about hazardous drugs before we make a decision here.
Okay. So those
Mark-
move to, yep, go ahead.
Mark, to your point, to me, like there's a difference between handling and there's a difference between compounding. And I think even splitting tablets is different than compounding with bulk powders when you're talking about the 3 different categories of the items on the items of on the NIOSH list. So is our only references, and I need to go back and look for 800, including the handling of the drugs in this chapter, or is it elsewhere, Cam? I can't remember off the top of my head.
I couldn't answer that right now, Madam Chair.
Lori, is your question, where does 800 exist in our code right now?
Yeah, like in the terms of like the handling of things, because 800 allows for assessment of risk when you're talking about just the standard handling of drugs, right? And would apply even to, like you said, items that are on the category 3 list.
I don't believe it's
It's a good
addressed in
question.
it's not addressed in our
Yeah.
statutes or rules at all right now.
Okay.
No, I don't think it is.
I just want to make sure that we don't impact taking pills out of a big bottle and putting them in a small bottle for things that aren't really truly manipulated other than the purposes of counting, if they can be addressed as a statement of risk and an assessment of risk.
Yeah, I think this one is not just counting, it's actually splitting tablets, breaking or cutting tablets.
And my intent here was to exempt that from calling it compounding.
Including
And
for
we could
including
stay,
for
we could stay
items on the
silent on it.
including for items on the NIOSH list.
Well,
Is
and
what
that's
you're
where
saying.
Cam was going. Well, that's where Cam was going. Should we say except for the hazardous drugs? And I think we need to decide where do we feel comfortable with drawing the line between a hazardous and a non-hazardous drug under Arizona rules. And I think we have to go back to this after we decide that. That would be my recommendation.
Okay, so I'll leave question marks on that for further discussion after and we'll circle back. That's all right, Madam Chair. For the longest time, this number 5, flavoring RX has been in our substantive policy section. And it's going to be nice to finally remove it if we can agree on this language. Thoughts?
And where did the 5% come from? Just because that's in the policy?
So I might have put it there. I don't remember where I got it, but I'm thinking 5% is half of 10%, which is a really, really safe place to be. And if the FDA allows compounders to be plus or minus 10% on the labeled ingredient, 5% is a really good cushion. And in my experience as a pharmacist, and it's been some time since I've been behind the bench and flavored things, 5% is a lot of volume, and you could probably flavor anything with less than 5% volume. So I will admit that I am acting without very much science here, but that was where I came up with 5%.
Yeah,
It
and,
is
you know,
a-
I can.
It
Go
is
ahead.
in the substantive policy too. It's 5% in the
Okay.
substantive policy, but your description is much more fun.
Yeah, and
Okay.
I think it makes sense, Mark, just to add to what you were saying, because I believe generic drugs, right? There's a variability. That's why they call them similar and not identical. Because FDA does allow some variability in generic manufacturing as well from the brand name.
So
So
they allow variability for the brand name companies too.
exactly. And I've
Yeah.
heard anywhere from 5 or 7% variability, but I can't, don't hold me to it.
Okay, I just want to make sure I understood where it was coming from.
So any thoughts on number 5? Everybody in agreement?
I like it.
Now, before we leave there, Madam Chair, you talked about the simple compounding, and we'll go back. I don't know, now might be a good time to talk about things like magic mouthwash that are so simple, and maybe you want to exempt them to allow all of the pharmacies, hospital, community, long-term care, to do simple compounding without having to go through all of the USP, and it would be for non-sterile products, my proposal, and not have to go through all of the documentation and rigmarole for 795. Now, the criticism of that would be, which lot number of Maalox and Benadryl and viscous lidocaine did I use, and what if they're recalled? My rebuttal to that would be, well, in a worst case scenario, patient level recalls are not common. Worst case scenario, I get a notice that a lot of viscous lidocaine or a lot of Maalox made after a certain date is recalled. I got to recall all of my magic mouthwashes that are probably already consumed by now anyway. And so you could create a policy around that to accommodate for that rare circumstance.
So if I were to look at what's been done in some other states, the state that pops to my mind is Mississippi. So Mississippi has language in their rules that exempt certain products. So for the purpose, just read it for the purposes of this article, because I don't think I can share it in the chat. For the purposes of the article, the combining of commercially manufactured, ready-to-use products shall be exempt from USP 795 compounding standards under the following condition. Number 1, no more than 4 commercially manufactured, ready-to-use products that have not been manipulated are used. Compounding is not done in anticipation of medication orders. Must follow the USP 795 beyond use dates. A valid prescription shall serve as the compounding record. The prescription label shall comply with the labeling requirements as set forth in this article of the regulations, but also must include the name of the preparation, the strength and concentration of each component, the beyond use date, special storage requirements, and cautionary auxiliary labels if applicable.
I love that.
Can we
I vote aye.
I'm fine with it, other than I don't want to give Mississippi credit.
I'm
The
all
Yankee
about
from the North record is noted.
I mean, I'm all about let's not reinvent the wheel. This has been in place, I think, for 2 years in Mississippi.
Thoughts, anyone?
I'm just throwing it out there as an idea.
I think it's really well done and really thoughtful. And I can't criticize it at all.
Even if it is from Mississippi, Roger.
It just scares me to copy Mississippi.
Hey, a good idea is a good idea.
Agree.
Here, Kim, I'll send it to you.
Yeah, I'm just putting a placeholder here. All right, next section. A pharmacy permittee or pharmacist ensure compliance with the provisions in this subsection. So we added, looks like A, B, C, and then moved some items down. Are drug substances that are components of drugs approved by the United States Secretary of Health and Human Services.
So I'll give you a little background here for context. What I tried to do here was marry the federal rules that already exist, and you could argue A, B, and C are already addressed in federal law and not necessary, because I copied that language from federal rules. But it is really important to Arizona pharmacists that we keep what has been in our code for a long time that are more, that allow more than just the federal rules. And the quintessential example are the pharmacies that compound allergen extracts that do not meet the first three, but have special FDA guidelines that even the FDA uses their enforcement discretion for, or for our flavoring agents. You'll notice that our flavoring agents are not going to be any of those components that are in A, B, or C, but are usually they're usually FCC grade, our flavoring components. And so I don't know if we need to add very much language here. The other thing I'd recommend as we read this is in context of some of the controversy that California started, which is which USP formulary, so you look at 1B, which USP formulary are we using? Is it the USP formulary in toto, or is it just the drug monographs and not the supplement monographs? And I would argue to remove the supplement monographs is going to create holy hell, and it already has in California, not being able to compound with glutathione and vitamin C and vitamin B and all of those things, and that's just silly. We should be able to continue to compound with those. And so that's the context for what you're reading here. I just thought I'd lay that out.
Is this in line with the 503 language with the FDA too? Is that what you're saying?
Yeah, those A, B, and C's are just borrowed from 503A.
Any thoughts, anybody? Okay, so if we can move.
I'm good with that.
All right, so the next two items, which hasn't changed much, just moved down. Thoughts on that, to keep or adjust or?
You mean the other two?
The existing
B
language.
and E?
Yep.
So
I think the concern I run into with here is how does a pharmacist know it's of high quality?
well, are of high quality, such as chemically pure,
Yep.
analytical reagent, ACC, FCC, or obtained by a source that in the professional judgment of the pharmacist is acceptable and reliable, and then permitted by the board. And that would give you the authority to create your own negative list if you wanted to. I don't recommend it, but I'll tell you, particularly with flavoring agents, for example, veterinary compounding. One of the most effective flavoring agents is a product that John Musil created called Triple Fish. It is literally a puree of tuna fish, salmon, and some other fish that comes in a can. And it has resulted in many, many, many felines getting the medicine they need and keeping them alive for a long time. It is literally a food, and in the professional judgment of the pharmacist, we said we think it's safe to use canned fish and make a puree out of it and give it to cats because it was a godsend for a lot of the cats. And I think you got to trust us. That's my point. We're not going to do something that's unsafe for the patient.
Any thoughts?
And for the record, this has been a part of our code for a really, really long time, and I don't think the board, in my memory, has ever needed to be concerned that this was overly permissive because I don't know. I can't remember a complaint where we went, we shouldn't have put that provision in our regulations because it's getting us in trouble and resulting in patient harm or patient complaints.
Mark, what do you add and permitted by the board?
So I was waiting for this conversation, and maybe I shouldn't have anticipated the conversation. I don't like and permitted by the board, but I thought it might soften it a little bit to allow you to create a negative list if you wanted to. But I don't think we should get into the business of doing that because the FDA is in the business of doing that.
Well, I don't think the intent, to me, when I read it, and permitted by the board means issuing a permit for this entity, not writing a negative list.
Oh, well, then we should clarify that. There's one thing my contracts professor described to me. If it's not in plain English and there's two different interpretations, you wrote the language wrong, Mark. It's interesting. It's the old language only allowed a pharmacy permittee to ensure compliance, and I thought that was a drafting error. I think both the permittee and the pharmacist have a joint responsibility to make sure this section is here, and maybe that's why and permitted by the board was down here. I can think of situations where we're trying to get away from the pharmacist has to work inside the four walls of a permitted space. I can't think of in the world of compounding when the pharmacist would not be in there, except maybe for pharmacists that are working on the floor of a hospital outside of the permitted space, long-term care centers where they're on site preparing certain things on site at the long-term care center where there isn't a permitted space. And so if maybe we should provide more allowance for the not tying the pharmacist to the four walls of the permitted space when it makes sense.
Tim, I did not read Mark's language as requiring a formal quote permit because I would have thought that would have been a capital P, but I do think it's confusing. But I'm still not clear why I need to go to the board. Do I have to get to the board's permission? It's really confusing. If I want to compound and I have to ask the board, can I use a product? That's a 2 to 4 month process. That this doesn't make sense to me.
Well, and that was not my intention, Roger, that there would need to be a permission slip. So, yeah, that was not the intention of that language at all.
So is it acceptable, reliable, and not prohibited by the board?
That might be better, but I mean, I don't know. Do we need it at all? Cam's writing some new stuff here. Might be helpful. Well, and see, I don't think these products necessarily need to be registered with the FDA or obtained from there. Flavoring agents is the best example, and allergenic extracts are another example of things that are compounded with every day that don't come from an FDA registered facility, but in the professional judgment of the pharmacist are necessary and safe for the patient.
So Mark, could we just take out that last end where it says and?
I
Would
think
that
so.
be
We can just
acceptable?
go back to the original language, and I feel horrible I tried to mess with it. Like, to my point, I don't think this section has ever led us into trouble. And the board could always question the professional judgment of the pharmacist in the future and still can do that if there was
Well,
a problem.
that's the thing. It's like we did have a case where an entity shipped product to a pharmacy with the appropriate paperwork that it was analyzed and so forth. Now, how was a pharmacist supposed to determine whether this came from a reliable source because there was a false document that was sent along with the product?
Well, that's criminal misconduct, and
That is, but then it's kind of
I
like
don't know.
using-
We use our professional judgment all the time to try to prevent fraudulent prescriptions, and
Mhm.
we're not magicians. We can't catch them all. And if there's a criminal actor out there, then that's why the FDA Office of Criminal Investigation exists, and the Attorney General exists, and law enforcement. We can't regulate out criminal misconduct. That's a different code.
I think my
But I
intent.
get it. I get there are examples where things slip through the cracks for sure. Prior to your tenure, I was involved in I was a witness to the state and federal government to a counterfeiting ring, and it was very sophisticated and fooled hundreds of pharmacies across the United States, including the regulators. But they were caught eventually.
Madam Chair, if it's okay, I'm going to noodle this around a little more, if that's, because I mean, it'd be
That-
nice to close the loop a little bit, but
I agree, but it makes sense what Mark is talking about, like an example of the product that Musil developed, right? If there's no evidence that it's caused harm and it improves patient care, whether it's in an animal or a person, why would we want to stand in the way of that?
The other example would be the ethyl alcohol example I got earlier. I lost the little vial for the clindamycin. There's no sense in throwing the whole thing away. I'll get some ethyl alcohol from another part of the store. It didn't come from an FDA registered source, but I have reason to believe that the ethyl alcohol that my company buys is from a legitimate source, and that it's really ethyl alcohol, and let's not stand in the way.
yeah, I think that's where a permit issued by the board, because then at least somebody has oversight, right? And if they've done something wrong, then we have jurisdiction. But I'll
You
give
have
it some more
jurisdiction
thought.
over the pharmacy. You don't have jurisdiction over the grocery store that doesn't have a pharmacy that I bought the tuna fish from.
No, agreed. There's gaps in that. That's kind of why I want to pull it back and give it some more thought.
Okay, all right.
Okay, Madam Chair, if we can move to the next section, number 2. I think this is more addressing, it looks like anticipatory compounding.
Yeah, so anticipatory compounding. This is something that, and I'll declare my conflict of interest. This is something that I've presented to the board on more than one occasion with considerable passion, and to the FDA. And the FDA has had not negative remarks, but not expressly positive remarks either. But it goes to anticipatory compounding and the ability to within the shared services rules provide anticipatory compounding under those rules. So what do I mean by that? I believe that because our shared services rules, and this is 23.621, describes compounding in shared services, and as long as the pharmacies participating in the shared services follow the FDA guidelines for anticipatory compounding and stay within the safe harbors of those guidelines, there's no reason why a pharmacy couldn't make product in anticipation of a patient coming in to another pharmacy to pick up the medication. So, and the board has been concerned that this is tantamount to manufacturing and you're creating inventory for another pharmacy. But in a world where we've got new and improved requirements for USP 797 facilities, and we're going to talk about 800 facilities, rather than require every single pharmacy in the whole world that compounds, spend money on capital improvements, and more importantly, find the kind of talent that's necessary to handle sterile compounding, which is difficult to find. We already have a hard enough time finding enough technicians to staff our stores, let alone technicians with the special skill set to compound. This section would attempt to make it permissible, expressly permissible, for a pharmacy to perform anticipatory compounding, not just for itself, but for another pharmacy pursuant to the rules under our shared services rules.
And I think we further had a discussion, Mark, regarding that. I think the board's position was get the thumbs up from the FDA and we'll be okay with that. So I'm not sure where that.
And there are two communications from the FDA that I agree aren't expressly approving of them, but they don't prohibit them. And I wish the FDA would be more clear, and maybe this new regime will provide more clarity. But it doesn't make any sense at all that shared services is permitted in everything except anticipatory compounding. It just doesn't make any sense to me. And it also would improve access to medications to people in areas where there aren't the ability for these pharmacies to comply and build facilities that are compliant with 797 and 800. And it would also, in my mind, improve safety by making sure that the facilities that have both the infrastructure and the talent to compound safely are able to provide access to their products in more places and get to patients more quickly. Right now, the proposal is, Mark, I've got no problem with anticipatory compounding at the permitted site because the FDA allows it and obviously our rules allow it. But you can't send that to a pharmacy down the street or across the city or to one of the more rural communities because I'm worried that that's manufacturing. So what I'd like you to do, Mark, is just keep it in your pharmacy and FedEx it or deliver it to this patient in a rural community, which will cause delays in care. And it doesn't make any sense to me. And I'll stop talking. That's my pitch.
So can we discuss this without the shared services first, and then we come back to shared services? Because I got a couple nits on the language, just if it's just a single pharmacy. Why does it we have to have a history of the pharmacy receiving patient-specific prescriptions? Can't the pharmacist anticipate it reasonably?
Yeah.
I think right now, if I can jump in, the FDA already addresses anticipatory compounding to be about, what, 30 days, if I'm correct?
Well, 30 days. 30 days is what they will never question, but the FDA doesn't limit it to 30 days. But they've established if it's never more than 30 days, we're not even going to question it. But the FDA does allow in its guidance document longer than 30 days with appropriate facts and circumstances.
So do we really need to address it if the FDA sort of is ambiguous about that? If it's just a single pharmacy?
If it's just a single pharmacy, no,
That's
you can rely on FDA guidance, but it's FDA guidance and it's not in their statutes or rules.
Yeah.
I mean, I think it's useful for Arizona to say something on anticipatory compounding. in our rules, just so people know what it is.
But then do we need a time period? 30, 60, 90 days? I don't know, you know, I don't want them to compound for an entire year. Because it becomes,
Well, you could only compound it, you can only sit on your shelf through the BUD date.
yeah, exactly. No, I know.
So if you make a batch of 100 capsules and your BUD date on it is 6 months, and you've got, you know, you dispensed 30 and now you've got 70 left, I don't have a problem with them consuming those 70 for another 5 months, because otherwise you're just wasting product.
I just was concerned that this language here, it says solely is based on a history of the pharmacist receiving prescriptions. And I want to be able to anticipate. I mean, frankly, that's where some of the shortages come in and some of the issues to be able to do it so that there's legitimate anticipation of it.
Roger, you're right. And I borrowed this language from the FDA guidance document, and I'm not wed to it. I think you're right. I think a reasonable pharmacist knows by having a conversation with the prescriber in the community. Hey, I'm the new specialist in the community, just relocated here from somewhere. I'll tell you right now, I'm going to send some patients to your pharmacy for some prescriptions you've never done before. Can you get them ready? And that would be, that's not based on a history, but that's a reasonable circumstance. Anticipation of shortages. I'm seeing fewer and fewer of this at the wholesaler, and I want to get ahead of it because it takes some time to get sterility testing done on it, whatever it is.
So that's one. And then the second, why is this limited to human drug product? The last 3 words. Why can't this also?
Because I cut and pasted from the FDA document, and it was from CEDAR and not CVM.
All right, so
That's
just
my bad.
drug product. You don't need the word human there.
Correct.
Those are my 2 nits on the language. Then we can talk about the shared services, but I think that applies regardless of shared services. So,
Okay, so my takeaway is wordsmith language related to the history, the word history in there, and eliminate human drug product.
we'll eliminate the word human.
Okay. All right. Any other thoughts on this section? Okay. Roger, you want to address shared services or shall we move on?
Well, I mean, we can address it. Mark's made his arguments for it. I'm not against those arguments. I just didn't know where we were going. I didn't read this as being explicitly approving it for shared services. If we want to explicitly say that, I think we should.
Yeah, and I think the board had that discussion with Mark, and I think Mark, you and I have talked about it. If the FDA gives you a green light, and right now they're iffy on it, the board would be okay with that as well. But I don't think they're crystal clear on approving that process. Now, to you, if the new administration does it and the FDA changes its position or puts out a new guidance, obviously, our shared services would cover that model based on the FDA's guidance. But I think we're kind of piggybacking off of what their process is. I'm not sure if any further clarification needs it until the FDA changes its position.
I've said my piece. I don't have any more to add.
Right.
Cam, I agree. That's consistent with the conversations that we've had in the past with the board.
Guys, I know it's been an hour and 5-10 minutes. I don't know if you guys, anyone needs a little break, but we can go on if you'd like. I don't think we have a whole lot more to go through. Maybe we do, I don't know.
It looks like
Well,
we're
you've
on
got-
page 2 of 9.
Well,
3 of
the
9.
substantive piece that's left is hazardous drugs, and I'm
That should
guessing
go-
that'll be
That should go quickly.
a long conversation.
Yeah, the next section addresses, number 3 addresses veterinary. I don't see an objection. I believe that is in the guidance with the FDA. So if you're okay, Madam Chair, we'll just move forward.
Yes, I'm good.
All right. So we're on number 3. I think, Mark, you added language to D. Beyond use date based upon the pharmacist's professional judgment, but not more than the maximum limits recommended by USP.
Well, and so just to be
Unless-
clear, I'm using the 2020 BUDs and not the 2024 BUDs, which I think is important. The BUD discussion was well vetted in 2020 during the original appeal. It was a 3-day process. Our firm, Quinn Emanuel and Reed Smith, spent a considerable amount of time on the lack of science and evidence related to the arbitrary nature of BUDs that is in the 2020, the version that was effective 2024. It's interesting, most of the BUDs were shortened except for the immediate use, which was lengthened, which interestingly enough was odd to me. 100% of my clients would like us to go back to, and APC would support this too, going back to the BUDs that are published in the current USP that we're using right now, which was current 2020. And so we're not bringing in USP 2020 for everything, just beyond use dates.
So it's using the old definitions of the beyond use states, not the new definitions. Mark.
That's it. That's all it is. Correct. Keeping the beyond use dates the way they have been since 2020, and not using the shortened versions that are in 2024. And the big issue there has to do with sterile products. My big concern from a patient safety standpoint is the BUD dates, the default dates for some of the sterile products, the small batch sterile products, are so short that you can't get sterility testing on them. And it baffles me that the FDA and the USP would prefer we send out sterile products that are not tested for sterility, but have a short BUD date, than to allow us the regular BUD dates that are in 2020 that allow us to quarantine 100% of our batches, whether they be small or large batches, until we get sterility dating back. And as someone who compounds sterile products for many years, I would be scared to death to send out a product without sterility testing. But the new requirements that backs down the sterility dates to in some cases 3 days and 7 days, doesn't give me enough time to do sterility testing on them. And I don't understand why that's a good idea.
So I'm going to play devil's advocate here. And I would love the feedback from the other folks that compound more of these products, because this isn't an area that I participate in. But say we were to go back to the old standards and something bad were to happen to a patient. Why did we pick and choose one version versus another when we're talking about, in this case, especially sterile products, some of the most high-risk products that there are? But I'm by no means the
That's
expert.
my point. The high-risk products are less safe under the new ones than the old ones. And I don't know if Kevin Borg in particular is on. Kevin does a lot of sterile products. I think the old standards are safer for the sterile products versus the new ones. I think it's dangerous and reckless for the FDA to use arbitrary deadlines and BUDs that aren't supported by any science. Microorganisms don't have a calendar. I don't know why all of a sudden, you know, and these are remarkably round numbers that they've chosen for default BUD dates. You know, 7 days, 3 days, 30 days. It's never 4.5. It's never, because there's no science behind them. And so I would prefer a system that allows a pharmacy enough time to get sterility testing back on 100% of its stuff, if it chooses to do so, and not force them into a world where sometimes they'll just have to send them out before sterility testing comes back and hope for the best.
Hey, Mark, it's Kevin Borg. So just kind of going what you were saying. Yeah, I mean, we do a lot of pretty much 9 out of 10 things that we do are all high risk. So we're taking non-sterile ingredients, turning it into a sterile injection or bladder irrigation or whatever that looks like. But I mean, the only things that we're sending out for testing are things that we're required to, which are our batches. A lot of our things are one-off. So methylcobalamin, hydroxycobalamin, different concentrations for different kiddos. And if it's a one, you know, we're making an individual script for a patient, obviously, you know, and we're billing it to Access and we're getting paid way under our usual and customary. And then I'm expected to ship it for free. Yeah, I'm not sending that out for testing. You know, we're limited right now with these new guidelines, 4 days fridge, 45 days frozen. So, yeah, I mean, if we want to spend the money and get a, you know, an extended, you know, stability test done to where we can extend out, but so many of these things are various different strengths where it doesn't make sense for me to spend $25,000, $30,000 to get a BUD study done.
A couple of things.
That's the other thing, Madam Chair, for purposes of this and full disclosure, by leaving in that current language at the end of the sentence, that is also different than the new USP 2024 guidelines that would not allow for a stability test the way it's described there. Wait, hold on. Unless this publisher includes it. Never mind. I'm sorry. Stability indicating assays there. The last part of that sentence is consistent with the 2024 standards. Never mind.
Dr. Grundy, did you have something you wanted to add?
I did. I think Mark I'm sure you've addressed this with USP. Did you get a response back from them?
When we appealed the BUD dates?
Yep.
Yeah, they remanded it back to the executive committee, and the new executive committee essentially did the same thing. And candidly, if there was enough money to send the 3 law firms back to appeal it again, we would have won again. But the pharmacy profession ran out of money. That's the short story there. And it wasn't because of my firm's fees. There were 2 other much larger firms that were much more expensive.
So the second part of this section, though, unless there is published or unpublished stability test, which includes, doesn't that, so even if we adopt, let's say we adopt the newest version, doesn't that give you still a little bit of wiggle room to have that second section in there?
It does, but that stability indicating assay costs about $30,000 to $40,000 to perform. And no one has the ability to do that, except for the largest of the largest companies. And usually they'll pool their money together, and that's why unpublished is important there, because they're not submitting that to a peer-reviewed journal, but they're getting that and they're sharing it with each other because they've usually pooled their money together to come up with that test, to pay for that test. But that was another thing. Potency over time testing, which is the standard of care before USP 2024, has its faults, but it also has its practical applications when the alternative is cost prohibitive.
But the FDA has adopted the new version. So we would be in
USP has.
conflict. We would be in conflict.
No, USP has. practice of pharmacy is exclusively related to, is exclusively the state's jurisdiction. There is no FDA registration on my wall unless I'm a manufacturer.
No, but we've been noticed many times that the FDA is inspecting not just 503Bs, but 503As in the States.
Well,
So-
sure they have. And
Well,
they
they're-
do come in. They have jurisdiction over the products that we use and the products that we sell that cross state lines, but not the practice of pharmacy.
Kevin, thoughts here from you? Anybody else? I'm not the expert in sterile compounding. I mean, I'm gonna have to rely more on the experts of the others.
To Kevin's point, small batches, even under 2020, don't require sterility testing. But even larger batches under 2024 would also not require sterility testing, and that just doesn't make sense to me.
Who
I'm
else do
gonna-
we have on, who else do we have on the line that's sterile compounders? Kevin, Matt Pond, Dina, any thoughts from your standpoint?
In my opinion, I think the language is reasonable, Madam Chair. But unless there's a published or unpublished stability test, which includes testing using indicating assay data. I think for us, anytime when we compound, we always go off of the USP guidelines. And if there is no data available through the USP, then we'll contact the drug manufacturer. And we'll go off of their recommendation.
And the safety net here is, under the 2020 guidelines that we used and under state law before, we were allowed to use potency over time. This one takes away potency over time, and it is consistent with the more conservative stability indicating method assay. So you cannot extend even a 2020 BUD without a stability indicating assay, which Lloyd Allen, the late Lloyd Allen, and every other compounding expert has described as the gold standard for stability testing. We haven't required that in Arizona, and by adding that, you're adding the more conservative standard to extend a BUD date beyond the USP default dates. So it bridges both worlds of use the BUDs that are in 2020, but if you're going to go beyond them, you can't use potency over time or professional judgment. You've got to use the very expensive and reliable stability indicating assay.
I agree, Kevin.
Madam Chair, in the interest of time, maybe we could circle back if we have additional time at the end, but if we could just move forward and see if we can agree on other languages here.
That's fine.
Okay, so this next one, Mark, you just added pharmacist and permittee just to be all inclusive. I don't think there's not a heartburn over that.
Dr. Gandhi, under E, under the documents by handwritten, can we add verbiage for electronic initials and signatures? We use that in the hospitals now with the new EMRs.
This one right here?
Yes. Mm-hmm.
All right, next section.
I don't remember adding that parenthetical, but if I did, I don't think it's necessary because the protective apparel is going to be, the type of protective apparel is going to be described in the USP requirements based upon what you're doing.
Do we need to reference pharmacists engaged in compounding complies with good compounding practices as identified in USP? Do we need to say that, or?
Well, USP doesn't use that term, but I mean, 2A is old language and it's circular. We are in the section on current compounding practices. A is not necessary at all, but you could change it to shall comply, like similar to the above, which is shall comply with USP 795, 797, 800 as published in 2024, unless otherwise exempted in this section. So you could copy the language from above if you wanted to, or just reference the language above if you wanted to. But current good comping practices isn't a federal word, it's a state of Arizona word. I think it's the title to this section.
Okay. So the new F, you just added or pharmacist to it. Was there any other questions on this section at all, guys? All right.
And this is all sufficient space stuff, and I would just call this out. I think we're talking about sufficient state in all of our rules to be as determined by the pharmacist in charge. I don't know. But maybe when we harmonize and come to a decision on minimum space in other parts of the code, we can just reference that section.
I think that's fair until we get there.
Agreed.
I think we will get there. It's just a matter of when.
So here's a lot of language now.
So this deals with what's hazardous and non-hazardous. Your options are to just say 800 in toto, that's what's hazardous. If it's not described in 800, which references the NIOSH list, then we're going to go with that. One of the reasons why we delayed implementation of the new USP chapters is because 800 also includes lots and lots of other drugs that many compounding pharmacists, many physicians, and many patients would think would be silly and cost prohibitive, and perhaps if you don't have the facility, not having the ability to compound. The Arizona example is fluconazole, which we use in our canines. Lots and lots of our canines have valley fever, and they need very, very small, and in some cases, very, very large doses of fluconazole that aren't commercially available. To require every veterinary compounder in the state to handle those in a USP 800 negative clean room facility and store them in a negative facility would be cost prohibitive and unnecessary because they exist in category 3. Category 3 are drugs that present some sort of teratogen risk, and that's a really, really long list of things that can be handled outside of a negative pressure environment, and also are dependent on the volume. Now, I would argue that if I'm making fluconazole in a blender that requires a stepladder to fill, that ought to be in a negative pressure environment, but we don't have those facilities. Those are manufacturing facilities. we are making things in batches of 100 and 300 at a time. The biggest capsule machine I've ever seen in an Arizona community pharmacy is 300 count. You can do that in a biosafety cabinet with a respirator on, and the competent compounding pharmacies that are doing that are having their biosafety cabinets inspected on a frequent basis, usually semi-annually, and having their technicians and pharmacists wear respirators. And so that being said, it would be this proposes to remove the category 3 from drugs that have to be handled consistent with 800, but would still require categories 1 and 2 to be handled consistent with 800. And so category 1 are anti-neoplastics. Category 2 are non-anti-neoplastics that meet one or more criteria for a hazardous drug, including those with the manufacturer's safe handling guidance. And then category 3 are they're all non-anti-neoplastics that have a possibility to negatively impact women of childbearing age and pregnant women because they have teratogen risk.
But Mark, isn't there a
So-
new version, 2024 version of the NIOSH list? It's just 1 and 2. There's no 3.
Yeah.
Oh man, you're right. I'm sorry. Kevin, did you read the new one?
You know what? I should know this because we literally the last 2 days just went through our PCAB re-accreditation, and because we do hormones now, even though we've not enforced it here, we have to be certified as USP 800 compliant. So we are now going through creating all of our SOPs and everything like that. So that's a work in progress, literally as we speak at this moment.
All right, Cam and Madam Chair, maybe this was written before the new NIOSH chapter or the new NIOSH publication came out. We should probably propose new language because this is already moot, unless we went with this. But I don't think we should. I think we should look at 24's list and then. But what would be helpful maybe for this group is this group comfortable in concept of excluding category 3? And if they're not, then there's no point in creating some exceptions for those types of drugs.
Hi, this is Bina Patel. Yeah, I do agree. I think the new 2024 is referring to the table 2, that we could exclude those because those are ones with reproductive risk, right? And then my comment would be for table 1, even though they're all anti-neoplastics, we're seeing more and more MAB therapies, right, in our infusion clinics, which are not all anti-neoplastic. So maybe some reference to doing a risk assessment with the organization or the pharmacy, and then, a multidisciplinary, right, risk assessment, which NIOSH does allow us to do that, with some verbiage around that. But I do agree that the table 2 in the new group, we could exclude, or take a look at that list and we could exclude that.
So Madam Chair, if I can assign a homework assignment to, not myself, because I'm not the expert in this category, but Bina and Mark, do you mind redrafting this section?
Well, I don't mind at all. Bina, I'm happy to work with you on it. I'm skimming table 1 and table 2, and I get it. And I don't like that they consolidated the 3 into 2, but I do like the concept of risk assessment for some of the ones, because some of the ones, include now group 2A, which are probably carcinogenic to humans, and I don't know what that means. Everything's probably carcinogenic to humans. We haven't pulled saccharin from the market yet, I don't think, and I don't know, so.
Okay. So yeah, if you guys can work on it, get that back to me, that'd be awesome.
Okay.
I appreciate it.
Yeah, we can do that.
All right, next is container closure systems. Any
So this was
concerns?
just official compendium, and I'm just describing what that is, and that's the new one that was just published.
Yeah, I don't think,
There's nothing,
That's just by
there's nothing
reference.
substantive that's changed there. Yeah.
Can I just bring one point up? The one, 1C rotated so that the oldest approved stock is used first. Can we just remove that? Because we do look at expired products and remove those from stock. But, you know, putting this in the rules, I don't know if it's reasonable.
I guess if you dispense expired stuff, that's a problem in itself, right? So,
Yeah, I would agree. There might be a reason that, I mean, if someone opens up a container that accidentally, you know, they opened up the wrong container, we shouldn't throw it away. And if it's
so
still
my
safe to
question
use,
is,
we shouldn't
do we need any of this? Because I think adulteration kind of manages this whole section right here.
I think you're right. Stored off the floor is something that I know the inspectors inspect for, but they also have the ability to determine if it's an unsanitary condition or not, and so they still have the discretion to say, I don't like it, take it off the floor, put it somewhere else. This doesn't look sanitary to me.
So other thoughts from the task force committee? I mean, if you
I
got
would
a
agree.
grimy floor and you're storing product, obviously there's risk of adulteration or something that's happening, right? So I'm not sure if we need to spell out everything.
I would agree with that.
I think that's the end of our show here. So just some takeaways, if I can handle Mark Bina to work on this language that you see on the screen with the updated NIOSH published date. If it's all right, I'm gonna do some homework on this one because I think it needs further review. Mark, to reference 2020 versus 2024 version.
Sure, and I can help as part of your homework, and I'll promise to do a side-by-side on what's the difference if we adopted this.
And then there was just some adjustments earlier that we've made that I can easily modify. That's not a problem. And Lori, I don't know if you've already done so, but if you haven't, send me that language from Mississippi.
I already did it.
Perfect, thank you. And just some adjustments here and there. I think you've kind of seen the notes I was putting in. I don't think there was anything mind-blowing, just minor modifications. Going back to the splitting of tablets, though, I put a question mark on there.
So
I can possibly
let me
add
add that
language.
let me add that to our homework, Bina and mine, because that's going to require risk assessment. Some things we're going to be okay splitting on the counter, and some things we're going to recommend be done in an 800 environment.
Okay.
And so I think we need to work on this one too.
Sounds good. I think other than that, we got it covered, Madam Chair.
Can I, Dr. Gandhi, Madam Chair, can I bring in one more thing? So this was about the compounding practices. Are we going to be taking a look at the sterile pharmaceutical products section, which is R4 23670? Does that need updating based on the new USP 797 guidelines as well? It's on a different section.
We can. Maybe Bina, you and I can work on that too.
I have a draft I can send you. Just, we take a look at that. And yeah, but I'll work with you offline.
Yeah, the thing about 670 is it has some the minimum square footage things, which we're going to address more globally. And it's duplicative of USP 797. And we may be able to get rid of most of the language and just say, you know, related to, for example, you know, the ISO class environment and the types of equipment we use, which, you know, have to be disposable syringes, for example. Don't want people reusing the syringes. And and I think, let me see here, this section predates much of USP 797. So it was there. Arizona put it in when there wasn't a modern USP 797. And so I think it's contradictory and superlative now, so we may be able to trim it down.
Sounds
All right,
good.
so that's a takeaway for you and Bina as well, Mark.
Yeah, we'll take it. And sounds like she's already done the heavy lifting, and I'm super happy about that. Thank you, Bina.
You know, I like this new role of assigning homework. This is fun. Rather than getting homework. So, no, I do
Cam-
appreciate you guys from running with that. Thank you.
Cam, to try and keep things moving, do we want to try and pick a time now on the call for another meeting, or do you want to send out a doodle?
I'll send out a doodle. I know it's legislative session right now. And so, I mean, that's why some folks weren't able to attend as well. But I think a doodle would be the best option because I could ask for it today and it's going to change tomorrow.
Okay. Sounds good. Anything else for the good of the order?
Can I raise one issue, Lori? And it's compounding, but I'm not sure where it fits. And I just want us to think about it. With a number of pharmacies that ship across the country or into other states, different states are asking on renewals. If you are shipping compounded sterile product into their state, obviously, if you're a pharmacy that is compounding sterile product, that's easy to answer. But now that 503Bs can sell to 503As, there are a lot of 503As that are shipping compounded sterile product into states, but yet they are not sterile compounding pharmacies. And I'm trying to figure out what we want to do in Arizona with that. Is this information only? Do we want a list of pharmacies that compound sterile products? Do we want a list of pharmacies that ship compounded sterile products? And is that any different than shipping manufactured sterile products? But there's at least 7 states right now that are inquiring on their renewal forms, are you shipping compounded sterile products into our state?
Madam Chair, if I could chime in, one of the things I think it's fantastic that 503Bs are able to work with 503A pharmacies to allow access to patients who need sterile compounded medications, and the 503A can't do it. One of the things the board might want to consider is not prohibiting that practice, but considering whether or not that 503B is licensed by Arizona, so that there's no end around the 503B licensing requirement. So both the A and the B shipping into the state would need to have an Arizona permit.
I think that's where my thoughts were as well. Almost like a virtual manufacturer concept, you know, where you got the virtual man, but somebody else is making their product and they both have to be permitted as far as drugs go. So I'm of the same mindset. That would need a statutory adjustment, of course.
So that may be a recommendation that comes out of this committee for next year, but whatever. But I sort of raised it, and I think it's going to become more widespread. So.
Yeah, so I'll make a note on that rules package I'm working on towards the very end as a takeaway, so that we document we've had this discussion.
Thanks, Cam. Anything else? All right. Well, hearing none, I guess we can adjourn for the day. Thanks everybody for your time and participation. Hopefully we can get this moving.
Thank you, Lori.